Okay, so I think we'll begin. Thank you so much, everyone, for joining us today. My name is Amy Sam. I am the Health Education Project Specialist at the Maxwell and Eleanor Blum Patient Family Learning Center. Today's program is a special collaboration between the Blum Center and Mass General Hospital for Children. Before we get started, I just want to go over a few items with you all. Please note that today's session is being recorded for educational purposes. If you're interested in viewing the recording, you may visit the Blum Center website at massgeneral.org/Blum-Center. Please note that everyone is in listen-only mode. Everyone has been muted so that we can hear our guest speaker today. If you have any questions for our guest speaker, feel free to use the chat feature, which is located at the bottom of your screen. We'll have time for them in the end. Only Blum Center staff, co-host, and guest speaker will see your questions. Please do not ask any personal medical questions or share any personal medical information in the chat box. If you have a personal medical question, please ask your doctor. So next, I would like to introduce you all to Brianna Beckfold. She is the project manager and editor for Mass General Hospital for Children, and she will introduce you all to today's speaker.
Thank you, Amy. So good afternoon, everyone. I hope you're all doing well, and thank you for coming to the virtual session of the MGH Obesity Parenting Series, where experts share their knowledge with patients, family, and staff on various pediatric health topics. This year, we're co-hosting the series with the Blum Patient and Family Learning Center at Mass General. As Amy said, my name is Brianna Beckfold, and I'm a project manager and editor at Mass General Hospital for Children, which is the pediatric branch of Mass General. Today, we have Dr. Vibha Singhal, Director of the Pediatric Program at the MGH Weight Center and an endocrinologist in Pediatric Endocrinology. She's going to share insights and tips on how to manage obesity and overweight in children. So before we begin, I'd like to briefly introduce our speaker. Dr. Singhal earned her medical degree from the All India Institute of Medical Sciences, the top medical school in India, and recently a master's in public health from the T.H. Chan Harvard School of Public Health. She completed her residency at the Mayo Clinic in Rochester, New York. And after residency, she came to Mass General to complete a fellowship. In addition to her clinical care in pediatric endocrinology and the MGH Weight Center, she's presented her research nationally and internationally and has received federal funding to evaluate the changes in how the pancreas works after weight loss surgery, particularly gastric sleeve surgery in adolescents. As Dr. Singhal presents, we will take questions from the audience in the chat box, and from here, I will hand it off to our speaker.
Thank you, Amy. Thank you, Brianna. Thank you to everyone for coming during your lunch hour. I'm usually used to, of course, we're all learning the Zoom way of doing things, still a learning in progress. But please feel free to put your questions in the chat box. This is a huge topic, and we all know there are a lot of questions. So my goal is here to try and address as much of your questions as possible while I'll go through the slides too. So let me share my screen and we can start. Amy and Brianna, is my screen good? Okay, perfect. So these are my disclosures. I receive funding from the NIH, from the hospital, and through the NORCH. And our goals for today's talk would be mainly to address what is obesity? When do we say that an individual has obesity? What are the causes of obesity, and what can we do to prevent it? So obesity is a disease. In 2012, the American Medical Association labeled it as a disease. So I just want to go over what is a disease. In our definition terms, we say that disease is something that is an impairment of the normal state of living animal that interrupts or modifies their performance of the vital functions. So it has to be an impairment in their normal state, and that affects the vital functions. In obesity, we see that there is excess body fat that once accumulated to a certain level can cause an adverse effect on health. So there is an impairment of the normal state, which is excess body fat, and then it affects many, many health functions. So a technical definition, what we state is it's a chronic, so that means a disease that lasts more than 6 months, relapsing, which means it comes and goes, multifactorial, has lots and lots of causes, neurobehavioral, means it has an impact or it can be caused by changes in our nervous system and our behaviors, which increases the body fat. And it results in adverse metabolic, mechanical, and psychosocial health consequences. There was a recent publication that suggested that obesity may affect as many as 200 medical diseases. So cause them, increase, worsen them, or prolong them. And at least in children, where thankfully we have not had that long periods of obesity, but I myself have seen at least 15 to 20 complications of obesity, some of which are quite severe. So I would like to ask you to just think for a moment about any other disease that comes to your mind, which is chronic, relapsing, and could have multiple causes. Take a moment, anything in that your friend, your family member, any disease that you know. Something in my mind that comes could be hypertension, rheumatoid arthritis, diabetes. It is a chronic disease. It flares up and down, all of these, and they have multiple causes. And how do we usually treat it? And that also, I would just hold that thought and we'll come back to it later. So, and how do we estimate obesity? And I put here estimate because true assessment, as I told you, it is a disease of excess fat tissue. So to truly establish obesity, I have to measure fat tissue, which is not normally done in the clinical setting, only because it is a more involved sort of process. It's a body composition analysis. But we use sort of surrogate markers like the BMI index that I'll be talking about to estimate obesity, make a guess of how much the obesity is. So these are the growth charts that your primary care doctor plots in all the well-child checks for your children. And the one to your left is a weight chart. These are CDC charts. CDC, I just took an example of boys CDC chart. And the x-axis here, the horizontal axis is the age. And as you grow older, your weight is supposed to increase. So for this young man at 2, the weight was somewhere here, 12 kilos. And at 9 years of age, they're about 25, 30 pounds. So 30 kilos. So that's kind of the weight. And that's how we do the height on the right graph. I would like to point out, if you see the graph here, you will notice that the weight gain happens and then there's a slight dip and then the weight regain happens. So mostly children are supposed to not gain too much weight right before puberty and then they start gaining more. Unlike height, it just kind of keeps going and then of course we have puberty and the spurt comes. And we use these two measures to calculate BMI, which is body mass index, which is weight divided by height square. So this gives us an approximate measure of obesity, and I'll describe to you in the next slide. We have these different colors to guide us where the child is in terms of percentiles. So percentiles is if you line up 100 kids of the same sex and same age, most of them are going to fall around the central line. So this is the 50. So right smack in the middle, most of the kids are going to line around this range. And then you have a few who are lighter and few who are heavier, but still kind of in the normal weight zone. Same for height. So how do we use the BMI? And this is a BMI chart that is more recently available. And I will show the color coding is to establish obesity and then the severity of obesity. So between the 85th percentile, remember I showed you percentile for weight and length, and this is the percentile for BMI. So a 12-year-old boy in this instance should have a BMI that is below this range to be classified as having normal weight. If they're between 85 and 95, we call it overweight. And then above that, we call it obesity, 95th and higher. So we classify obesity based on how far you are from this 95th percent line. So the line right at the top of this yellow color. And the classification is meant to help us because higher you are above the normal chart, normal line, the higher the risk of complications. And also, in assessing the impact of our treatment, as to if we go from here to here, it is encouraging. Oh, we lost 10% in the terms of BMI. And here I would like to show you about the obesity rates across the world in children. And this is an online graph, which is data visualization. So I will have to stop this screen share and share with you another screen, which is right here. So if you see this graph, this is for 19-year-olds that I changed to 5-year-old females across the globe. The blue is very low rates of obesity, and as green is 2 to 5, 6%, and then yellow to orange to dark red. So if you keep an eye on this globe, we will notice that most of the westernized society is in orange to red. Here we go. This is Saudi Arabia, and you can hover and, it gives you idea of what percent of 5-year-old females in that country have obesity. And I will point out when we come to our country to see the numbers there, which is right here. So in the United States in 2016, 17% of 5-year-old girls had obesity, which is alarming. And let's go back to the slides here. And this is coming, evaluating national NHANES, we call the data from our country alone. And this is showing the trends of obesity in younger children, which is the darker blue, and then as they gain older. So about every fifth child has obesity in our country. And it continues to increase both in youth and in adults. So we have not achieved success in halting the increase in obesity rates. And this is in terms of severity of obesity. Again, we focus on severity because more severe the disease, more consequential. So this being the most severe obesity, thankfully, it is not as high as class 1, but it continues to increase. Another important fact that I like to remind myself, my colleagues, and also parents when I meet them is adult obesity is actually a pediatric disease. So this graph here shows what is the likelihood of having obesity as an adult at the age of 35 based on your weight status and the younger years. So if you're 5, the purple line shows that you had normal weight at the age of 5. So your risk of developing obesity at the age of 35 is very less, 30%. That is just our current rate. But on the other hand, if you have severe obesity, so remember the higher percentiles, as a teenager, so as a 15-year-old, if you have severe obesity, there is a 90%, 0.9 probability, 90% chance that you will have obesity as an adult. So, this is almost eye-opening in the sense that many culturally, we like, love is in feeding our children, or it's just simply hard because some of them can be stubborn in changing habits. But if we kind of put it in perspective as to the life of our child, it is really an important investment to address childhood obesity. And this graph just shows that the minority groups amongst us does not have the Asian crowd, which is where I would belong, but there is significant disparities that are established in terms of obesity prevalence way, way early in childhood. And this is again relevant in kind of elaborating on the same concept as the last slide, is that BMI trajectories who can resolve their obesity as a child and who cannot is kind of set very early. So these green curves are the children who were able to resolve their obesity by adulthood, whereas the orange curves are children who could not. So the curves started separating almost as early as 6 years of age. And we see slower increases in BMI in the children who resolve their obesity. And finally, if you were able to stabilize your weight by the teenagers, then there is higher likelihood that you will be able to resolve your obesity. So if I'm seeing a teenager at the age of 16, 17, and they have high, severe obesity, and it is not improving, that pretty much tells me that it's a very, very high risk of having obesity as an adult. So I feel imperative to discuss with the patient, the families, that we really need to take steps now. And of course, the pandemic kind of put right in our faces the consequences of obesity. It's the pandemic within an epidemic of obesity. When we were hit, obesity shifted the COVID-19 to younger population. So the younger adults who had obesity suffered from more severe disease and more severe complications. So far we have discussed that obesity is a disease, rates of obesity are increasing, childhood obesity strongly tracks into adulthood, and the previous notion of growing into your weight is really not supported by data and evidence. So BMI is one of the measures that we commonly use to track and grade obesity. Now, there are caveats. I sometimes will see athletes who have very high lean mass and their BMI is kind of on the higher end. So in those rare instances, we do a body composition analysis to see if it's truly fat or if it's muscle. But overall, BMI is one of the measures commonly used to track and grade obesity. So moving on to our next goal of what are the causes of obesity. It's basically a very simple thermodynamic equation of energy in, energy out, right? So it's weight and energy balance. The amount of calories you take in and the amount it is used in different things for basic functioning, for exercise, for digesting our food. If you're in hot weather, your metabolism is higher. So a lot of factors come into play, but it's physics. You consume calories, you use calories, whatever is remaining is going to be stored. But what another thing, physiology comes on top of it. Our bodies work to regulate that energy balance. So the weight and energy balance is regulated by brain, and the body strives hard to maintain a constant amount of adipose tissue. So the body wants to keep the fat amount same throughout the life. It does, like it maintains the red cell amount, that you don't get anemia or don't have too much high hemoglobin. It wants to keep the fat amount consistent. And why do I say that? Because, to maintain an adult body weight, let's say somebody was 150 pounds as an adult or at 35 years of age, and to be within 130 to 170 pounds, so within 20 pounds of that 150 pounds, they have to consume just one extra potato chip a day. So that's how tightly it is regulated. And many of us can maintain body weight within 20 pounds as an adult. So the body is somehow able to regulate our energy in and energy out so that the fat mass is largely maintained. So the system works many times. And another example is, say we have a diarrheal illness, we lose 5 pounds because we didn't eat. What happens when we feel better? We gain all our weight back, and pretty much to the weight where we started. So it's something is bringing that balance back, right? If you donate blood, you lose some blood cells, but within a week or two, the body makes enough blood to get you back to that level. Similarly, so this is called homeostasis in our physiological terms, that the body regulates very well. But unfortunately, in obesity, this regulation does not seem to work. So there is some change in the body that is preventing that regulation, that homeostasis. So there is an abnormality in the body that is causing that change. So take, for example, high blood pressure. Kidneys play an important role in maintaining the blood pressure. But when we start with mild hypertension or high blood pressure, that regulation is lost. The kidneys are not able to do that efficiently. And then we ask of ourselves to eat low salt diet, increase potassium, lose some weight, and the kidneys may come back. But if that continues, that insult continues, we keep losing our regulation. So in obesity, the body is not able to regulate the tight homeostasis that is needed to maintain the fat mass. Please don't be overwhelmed with this complicated picture, but I just wanted to show you that it is very complicated. The energy regulation is tight. So the brain, if I may have your attention at the bottom of the cartoon here, is taking signals from different organs, muscle, which is using energy, is sending its different signals through different hormones, different metabolites to signal that I have worked hard, I've lost calories or not. Pancreas, which makes insulin and responds to food intake. Our fat cells, liver, gut, makes a lot of hormones. Gut is a house of more than 1 million bacteria, which are also contributing to those signals. So all these signals through the hormones, through the nerves, through the byproducts of the food we eat, the kind of food we eat, affect the brain. And in the brain, there are almost pockets. One is called the metabolic brain, so the one that really regulates energy in and out. And then there is the cognitive or emotional brain, which seems to be influenced by many things that are that seem to be the primary cause of disrupting this regulation in our food replete world. So taste and smell and palatability, the bright red Doritos pack, the bright yellow Lay's chips pack, the look, the visual appeal of those packages, the smell of cookies, all this feeds into our memory, into our emotions. The brain cells light up, the happy areas light up way more when we eat a cookie than when we eat carrots. So there is truth in this reward or feeling pleasure by eating those calorie-dense food. Clock is very important as to when you eat. Breakfast is an important meal of the day. Eating too late in the day is not healthy. Our social habits. Can I eat a slice of pizza in a college pizza party after I've had a full meal, or am I full? Those are social habits. So all these play and send signals into the brain, and then sort of control, do we eat more or not? And of course, there are different factors that each individual is unique in, as in what happened in early life, in pregnancy. We know that babies who are born small, or if there was intrauterine gestational retardation, those babies are more susceptible to gaining weight because they are trained to hold on to calories to survive the intrauterine period. There are some changes in the epigenetics in our genes. If there is too much antibiotic exposure, and now there's thought about the mode of delivery. So there are a lot of individual factors that play into this whole feedback to change our susceptibility to obesity. So obesity is a malfunction of physiological processes that regulate our body's fat mass set point, and where an elevated fat mass set point is defended. So the last part, our body is letting us gain more fat mass and likes that fat mass. So that's why whenever you lose weight, our body tries to bring us back to the previous fat mass set point. So what is the fat mass set point? What are the factors that can affect it? So I'm going to take my own example in genetics. I have two parents. One, my mom has overweight. My father has obesity. I am Asian. So we Asian women in general have higher fat mass. So genetics definitely plays a role. And on top of that, we are exposed to processed diets, irregular eating patterns. So all these things contribute to changing that fat mass set point that the body is fighting. And then we have inadequate physical activity, inadequate sleep, stress, and weight increasing medications, and finally life changes. Periods, menarche is in girls, puberty is another big factor in young children when they're growing. So all of these can impact where our body defends our fat mass. So the key message here is that I would really like for you to take and spread is that obesity is really not a disease of willpower. So there should be no self-blame. It's a disease that results from a change in fat mass set point from physiological malfunctioning. I agree that the initial insult could be all those behaviors, but how long of that insult, once that insult is established and our fat mass is changed, it's really not a matter of just eat less, walk more. That will help, but it's not all that. There is more that the body is going through. So there are some modifiable and some non-modifiable factors that result in this change. So we should work hard on changing the modifiable factors, but also realize that there are a lot of things that we cannot change. So at this point, I think I'd like to take a brief break and ask the audience to put in some questions, because I feel I threw in some new concepts, or maybe not. But I would love to hear from you and see what questions you have, and then we'll get to the next stage of what can we do.
Great. So like Vibha mentioned, if you have questions at this point, please put them in the chat box. And I have one coming through so far. And it's, how can you talk to your child about their weight without unintentionally body shaming?
Very good question. When I do it, of course, parents know their child the best. There are some books that are available, and I'm happy to give references to those books. But I don't call obesity, I call weight struggles. Taking your own example, if you struggle, and putting it in a very general, not in a pointed way. I totally hear what you are asking, because I see this in office, and food becomes the worst time for families to be eating together and pointing that out. So one thing is, change the environment. If you want your child to eat something, don't have the other option available that is not healthy. So meal times should be an opportunity to model the right behaviors. The portion sizes. So the whole family should be doing the same thing and not singling out, even if your child is the only one who is having weight struggles. So I have two boys. One can't gain weight, the other gains weight with air. So how do I balance this? My weight gainer was gaining a lot of weight, and I had to do something. And they both like cookies, they both like chips, but I had to intervene, and the whole environment was changed. So there was a time when there was no cookies and no chips, which is not even healthy for the lean one. Everybody should be eating healthy. So putting more in terms of health and less in terms of a number. It's not about the focus on the number. It's not about the scale. It's about being healthy, doing it together, and using it more as an opportunity for the family to change. Now, if the issue is coming more from external feeding, when kids go out, they have their own money and they do their own thing, and you can't control, I hear you. So there are some things you can modify and can change. Others, it's just repeated reinforcement, and it's not easy, but we have to just keep doing. There's no magic wand here.
Okay.
Any other questions, Brianna?
I don't see any at the moment, but I'm sure more will definitely come through.
Okay.
Yeah, so why don't we move on to the next slide, and then for anyone else who has questions, please enter them in the chat box and we will get to them at the end.
Perfect. All right, so last but not the least, how can we prevent obesity? So again, these are going to be a bit loaded, these slides, and each point is almost like a talk in itself. So again, feel free to please ask questions if you have any, so that I can address your particular questions. In terms of nutrition, there are different aspects to it. One is, calorie is a calorie, but different calories can have different impact. So the quality of calorie is very important, especially when it comes to carbohydrates. So it is very revealing when you talk to, how you communicate, of course, very much differs if it's a young child who you totally control everything, versus if it's a teenager who have much more control over their own food intake. So when I talk to them, I will discuss macronutrients. Do you know what protein is, what carbohydrates is, and what fats are? So giving them, we'll give them homework to sort of read about these things. And I ask them to just play around with, what does a regular bag of chips or white bread or one bowl of pasta, can you please go measure a bowl of pasta and a cup of pasta, white pasta, and then see how many calories there are in that pasta. So just a visual, a practical experiment can be an eye opener. It was for me. It was for my kids, and teaching them how to read labels can be helpful. So we of course know, watching the kind of carbohydrates, processed, too white. The plate should not be very white. Food should not be very white. That means it's highly processed. Adding color to it. Something that works with children is, oh, you should have at least 3 different colors in your plate. What red thing do you want? What green thing do you want? Again, giving them choices that are both acceptable to you. Do you want an orange or do you want strawberries? And portioning it. So I have a lot of my parents would just, even if you're getting a big bag of even chips or baked stuff, the big bags are cheaper. Please go home and portion them into smaller size, and your child should have access to only 1 or 2 portions. So doing that, it's work. It's not trivial. It is work. But I think in my mind and in most parents' mind, it's worth taking on. Fiber fills us up. It's the first cues of filling, of satiety, come from the distension of the stomach. That's why sometimes I'll say the sequence of food should be a salad or a vegetable or a fruit in the beginning of the meal, and then save your yummy carbs for the last, because your stomach is filling up. You will tend to eat less. The second is, another thing in, I'm sort of diverting a little bit, but how fast you eat. Some kids just breathe their food in. So I will sometimes have a timer and ask parents to divide the portion into 2. So give half the portion size in a smaller plate, in a smaller bowl, and then if they have eaten it in less than 10 minutes, they will have to wait to get their second half. That just helps the body send signal to the brain that you have eaten enough. And they will come back many times and tell, yeah, the second portions are decreasing in volume. So all those things impact. And again, macronutrients. People will, there is a big thing about keto diet. We don't generally recommend taking out any macronutrients, especially in growing children, because we just don't have enough data. And there have been some side effects of keto diet in terms of higher lipid levels. So we generally don't recommend, but there are people who would try it, and sometimes it works and sometimes it doesn't work. And the other big thing in terms of nutrition is quantity. Of course, the portion size matters. And there are lots and lots of images that kids these days learn in school, and we see about how your plate should be divided. Half vegetables, quarter of it should be a protein, and then just a quarter of it should be the pasta or the rice or the tortillas, and of the carb portion. Calorie tracking is, I only advise it to somebody who wants to do it because it is tedious. I will occasionally say maybe on one weekend day you could try and do it, again, to give you an introspection into how much you're eating. And finally, the timing. Many teenagers will eat all their food in the evening, all their calories in the evening. Not a good idea. So I have felt that while their motivation is not the strongest, but having a motivation focused on what matters to them. They are not going to be scared of diabetes or hypertension, but they may want to fit in a certain dress for prom. So using the motivation that will drive them to get to their goals and dividing the goals, not a 20-pound weight loss goal, 5-pound weight loss goal, smaller steps, helps teenagers to see, and then positive reinforcement on changing in behaviors. So the other big thing is, oh, I tried it for 3 weeks and then nothing happened, so I went back. Well, that is normal. It takes time for the behaviors to show an effect. We, on an average, say 3 months of behavior change to actually see a change in dress size, how your clothes fit, not just a scale. Scale is not the end all be all. And intermittent fasting or time restricted feeding is another thing where people fast for a few days or eat only for 6 to 8 hours of the day. There is some scientific evidence to suggest that time restricted feeding might work. It decreases some hormone levels that help in prolonged life, decrease the metabolic consequences like diabetes and high blood pressure. So there may be some benefit in doing that. And could be a discussion with your nutritionist or your doctor. Any questions on nutrition? Brianna, I see something in the chat. Should we take it now?
Sure, if you'd like to. So our question is, by limiting chips and cookies in the home, is there data to support children feeling deprived and therefore wanting those foods more often?
Very insightful question. I am not aware of data, but I can tell you that yes, they do feel like that. So again, those are treats. Not having chips and cookies in home is fine, as long as they can get a cookie once a week in a limited size. So instead of eating a box of cookies in a week, they will get 1 cookie a week. So of course, we do not want to deprive kids. We want to expose them to all the yummy food, but it should be viewed as a treat, as it should be. That's how, before the higher rates of obesity were, that's how homes used to be, regular cooking, not processed foods available. If you are hungry, you eat a snack of, an apple maybe. But you will get a cookie as a treat. You will get birthday cake as a treat. Nobody should not eat a birthday cake at the friend's birthday party. But a bowl of ice cream every day is not needed. So if they're getting in between those treats, then I would suspect the deprivation feeling would not be there.
Okay.
All right.
Mm-hmm.
So coming on to, are there other questions, Brianna?
Not at this point, no.
Okay. So exercise, which is a must for good metabolic health, even at the same weight level, if a child is exercising and another child is not, the one who is exercising will definitely have a better health, better heart health, will prevent diabetes, will manage the high blood pressure much better than one who's not. And general feeling of fitness and well-being, mental health. So I cannot even stop and enlist all the benefits of exercise. It's improving the brain power, cognition, so multiple effects of exercise. And it doesn't have to be long bouts. It can be, newer data suggests 10 minutes, 2 times a day. 10 minutes really doesn't take a lot. So sometimes I will tell, even if you're on a phone with your friend, be walking in the house or in a safe area for 10 minutes and talk. So very important in weight loss maintenance. So building that muscle, that efficient muscle that uses more calories even when you are sitting than a muscle that has not been used for a while is very, very essential. But many studies suggest that it is not so effective, at least directly, in terms of weight loss when used alone. So if somebody is not watching their diet at all, but is exercising an hour or two, 2 to 3 hours a week, that is not going to cause weight loss. And this is, again, a simple thermodynamic equation. So to cause about a pound of weight loss, you have to be in a calorie deficit about 3,500 to 4,000 calories. And this means about 10 hours of aerobic activity. So if you put it together, it is a lot. But if you are, watching your diet and decreasing 400, 500 calories a day, you can get to this in a week. Many parents will come and tell me that their main reason for the child gaining weight is because they're not exercising, which may or may not be true. Again, exercise is very important and they must exercise. And the recommendation from the American Academy of Pediatrics is about an hour to 2, depending on the age, every day, which should be done and should be enforced. But to expect weight loss from exercise typically does not happen. Type of exercise may matter. The muscle building, the resistance exercise, again, to make the efficiency of the muscle is crucial. So we have to have a mix of both aerobic, cardio, and resistance training. And then stress and mental health. Very, very important. And the prime example we saw last year with a significant increase in childhood obesity. There was a study that showed that the increases in obesity rates in children last year were almost similar to that happened in 2 decades before that. So the 2 decades effect was summarized in 1 year last year. That's the effect of stress and mental health and not going outside. And it was across the board for children with normal weight to children with obesity. Because mental health and stress directly impacts the appetite centers. So remember the cognitive and emotional brain, that feeds directly into our appetite. The appetite center and the mood center are like sitting right next to each other and they talk. I can vouch for boredom eating, for low mood eating, for tiredness eating. All those are real things. And part of the program, part of attacking obesity is understanding what is the trigger for this particular person. Obesity is a very, very complicated, heterogeneous disease. It's not one treatment fits all. I will talk about mindfulness practices, just taking deep breaths before eating, before starting to eat. Smell the food, taste the food after each spoon, like actually practicing to use all the 5 senses before eating. And we have programs where our psychologists will talk about all this and train for all this. There are studies in little babies showing that some eating behaviors, how fast they finish their milk bottle, how much are they fed on cue of hunger, or they're just fed at clock, like every 2 hours. All these factors can have an effect on their fat mass later in life. So seeking and getting help is crucial. Depression is associated with eating disorders and eating more or less. And then finally, watching for bullying. I'm sure you are all aware of this, but I can't tell you the number of times children decide to do homeschooling because of bullying related to weight. So all very important factors. Sleep. Numerous studies show the impact of quantity and quality of sleep. It's not just the hours. Hours are very important, but also the quality. So do you have sleep apnea? Do you snore? Do you wake up 3 times at night? What are your hours of sleeping? And of course, electronics are a big bane in that regard. So again, reinforcing over and over again, the blue light that comes from the phones keeps our awake center bright. It will not let you sleep. So if you are watching your phone or any eye devices before sleeping, it will prevent you from sleeping. So there are cases where just fixing the sleep apnea, the child has come to normal weight zone. So this is not trivial and should definitely be considered. There's some disorders like PCOS and risk of diabetes that are all made worse if you add sleep, bad sleep to the mix of obesity. And finally, weight promoting medications. Long-term use of steroids, some psychotropic mood altering medications, insulin, beta blockers, and I put OCPs or birth control, estrogen, progesterone pills in bracket here, which may or may not cause weight gain. But again, discussion with your doctor in finding an alternative is crucial. So treatment, again, the response is heterogeneous. You can take and put two individuals with same height and weight and on a similar diet. I can bet you they will not respond the same way. One could lose 20, 30 pounds and the other may not lose anything or may even gain. So treatment has to be sort of found for that person. If my problem is cravings for sweet food, I need to deal with that. If my problem is evening time eating, that is where my problem is, and I need to tackle that and encourage rest of the healthy behaviors that I'm doing rest of the day. So response is heterogeneous and treatment should be person-centric. It should be effective and durable, and durability is a big problem with weight loss because, again, our body fights. So we have to keep increasing our intensity of treatment. And then it has to be stage appropriate. And I will elaborate on this in a little bit too, but mild overweight can be tackled with just these behavior changes, or maybe one or two. But as the weight gain goes up, we have to throw in more. You have to fix the sleep, you have to decrease the stress, you have to eat healthy, you have to do all of that to cause a change. And then you may have to add another tool in terms of medications or, in extreme cases, surgical interventions. So it has to be stage appropriate. So I'm going to, again, as an example of stage appropriate, I'm going to show this example of a 9-year-old little boy who came in with increasing BMI. So this is the weight chart, but you can see the BMI chart corresponded. But the weight gain kind of crossed from this black line to the green line to almost touching the red line here. So jumping up two curves. And when you ask the history of diet, the little, although in a perfectly normal zone, right, under the 95th percentile, there are behaviors of grazing, eating more when tired, eating more of the processed foods. So discuss the changes, implemented the changes, and the weight gain stopped. So when you are just beginning, small changes of changing the environment and changing the kind of snacks led to an improvement in the BMI. So this was weight stabilization despite him keeping on gaining weight. And the BMI normalized. So this is an example of my little son who was the weight gainer and is doing fine now. Finally, this is the obesity pyramid that we take sort of from adults. But again, all these interventions need to be added on top of the other if we are failing with one therapy. So I really like to encourage, we are running out of time almost, to be strict and let's do it all, give it our best for 6 months, be disciplined, show the tough love, and let's do it. And if not, let's talk about the next stages. This, I just want to be showing you a quick example here. So this is another young lady that I saw in the practice who came in with very severe obesity and had a lot of complications. So in her case, she was trying her best to eat healthy and, we ruled out sleep apnea and all the things. So we had to add a medication, and she is close to their very lowest dose, and she's close to normal weight. So, and this is another extreme example of surgery. So things, depending on the stage and severity, we have to escalate our treatment. And even our American Academy of Pediatrics recommends weight loss after 6 years of age. Many a times we feel, oh, they're going to grow into their weight. So as long as they can maintain. No, after a certain stage of obesity, the target should be weight loss, even in our younger ones. So with that, thank you so much for your attention, and happy to take a few quick questions.
Great. Thank you, Vibha. Okay, so we have 2 questions so far. And the first one is, do you have any tips on keeping children active as it starts to get cooler and this family might not be comfortable bringing them to indoor public places?
So no, because of COVID, I'm guessing indoor public places are not the most comfortable option. So I, in my office, will ask them what their interest is. We will go to YouTube and identify a few videos that mom or dad or siblings and everybody joins in and participates. So there is a lot of variety in terms of Zumba, strength training, yoga. Yoga is not the best with kids, but some of them do like it. So that could be one option in your own home, as long as you have a little space to do that. Going up and down the flight of stairs 10 times. That is another, I can do that. That could be one option, depending on what kind of setup you have. And then, again, doing as a family together helps, and doing those, finding those happy things that can be done. Some video games are more active than others. So all those could be some examples.
Okay, great. And then our other question is there a time frame that you would recommend eating stops? So for example, stopping eating after a certain time at night, for example.
Yeah, so again, very good question. So I typically say sunset as kind of the ballpark, but sunset could be 4 in winters. So 3 to 4 hours before bedtime. Definitely the carb intakes should stop. So if you're having dinner at 5:36 or even earlier, it's likely that they'll be hungry by 8 and want something. So at that time, even if you need a snack, don't go for a carb. Go for some nuts. Go for maybe even peanut butter, something that is protein, because that does not require insulin, which is the hormone that doesn't work well in the evening time.
Okay.
Yeah.
Yeah. I think we've hit 1 o'clock, but thank you so much, Vibha. This is very informative, and I'm glad you could join us today.
Thank you. Thank you, everyone.
Thanks.
Thank you. And as I had mentioned earlier today, if you're interested in viewing the recording of today's session, it'll be made available on the Blum Center website at massgeneral.org/Blum-Center. Thank you so much, everyone, for joining us today. Have a lovely rest of the afternoon.
Thank you.